Our faculty and our moderator, everyone. I'm starting this program. Good evening to everyone. I'm Dr. Omkar Swami on behalf of MQ Pharmaceuticals Limited. I welcome you in a very interesting program of Attack Heart Attack. So in this webinar, we will be discussing about what are the options for management of acute myocardial infarction, particularly in COVID era. And to take this deliberation forward, we have today evening Dr. Tiny Nair sir, who will be moderating this session. It's very important to have sir in this session because when we launched this molecule in 2007, from then we have developed lot registry and we have pulled lot of data. And sir was with us from the beginning of this data. So we had first publication in 2008 in CSI Chennai with 510 patients who have received Elaxim. And then that database has grown up to almost 24,000 patients, and it is one of the largest database of post-marketing surveillance or the registry of Elaxim in acute myocardial infarction. And we have a multiple publications of based on that registry, and sir was part of in each 3 to 4 publications which has been done based on that registry. So it's very important and pertinent to have Dr. Tiny Nair sir in this program so that we can understand right from the beginning and where we have progressed. So we know sir is currently working as the head of the Department of Cardiology at PRS Hospital Trivandrum. Sir had been a recipient of Best Doctor Award from the Government of Kerala 2006 and also Most Inspiring Doctor of India by Economic Times 2019 and Best Reviewer of Annals of Internal Medicine, which is one of the very prestigious journal. And sir has been editorial board of hypertension, IHJ, European Journal of Heart Failure, and sir has been an author of 5 books, and latest is A Magic of Indian Medicine. Although I have not gone through this book, but must be very interesting. And sir has more than 50 publications and 3 national laureation, and sir has been a top writer of a blog called Quera and TEDx talk speaker. I have a very long association with sir. Sir has been my friend, philosopher, and guide, and always give me a new concept and new facet to the conventional thing. So thank you very much, sir. I always blessed to have a relationship and your guidance all this time. So thank you very much, sir. I also welcome today's speaker, Dr. Nigel Cletus. He is a consultant interventional cardiologist at Indira Gandhi Cooperative Hospital, Kochi. Sir will be presenting on STEMI management in cath lab during COVID times. We have second lecture by Dr. Renju Kumar BC. Sir is currently working as a consultant interventional cardiologist at Renai Medicity, Kochi. And sir will be talking about pharmacoinvasive approach in STEMI management. We have 2 senior panelists today who will be deliberating and taking out the pulse of wisdom. Dr. Bino Benjamin sir. Sir is currently working as a consultant interventional cardiologist at Jubilee Mention Medical College, Thrissur. And we also have Dr. Sajan Narayan, who is currently working as a senior consultant and interventional cardiologist at Little Flower Hospital and Research Institute, Kochi. So we will be having a lot of discussion today evening. This is the agenda of the program. We will be having first overview by Dr. Tiny Nair sir, then 2 back-to-back presentation, and we will have a panel discussion on the consensus of STEMI management in COVID era to reduce the COVID infected STEMI mortality and morbidity. With this short note, let's go back to our moderator for today's program to have the overview and take the proceedings of this meeting ahead. Over to you, sir.
Thank you, Dr. Omkar, for that nice introduction. I think this is a very, very important meeting as far as I'm concerned, because Dr. Nigel, Dr. Anju, Dr. Bino, Dr. Sajan. See, I have grown up in an era, older era, when I was in house surgeon, there was no treatment for acute myocardial infarction available. And I remember that in my final year, one of our professor of cardiology got a myocardial infarction, and he had taken 3 months of bed rest. And later on, when he became better, because his daughter, he was Professor Kaur, his daughter was our 1 year senior. So we used to go to his house, and we were very close as a family. And he used to tell that, because I'm a cardiologist, I know how important it is to take rest. So bed rest was the only treatment. And then and the fringe was some kind of heparin, and then came in all these ISIS and all the streptokinase came in. When the whole whole scenario of treatment changed. And then we got the newer thrombolytics, we got PCI, and today we stand at a different era altogether. Thinking about that old time, we were so kind of naive and foolish, right? So when we today talk about an acute myocardial infarction, certain things are basic. We need to open up the clogged artery, right? And when we do that, we have PCI in front of us, we have thrombolytic therapy in front of us, and data very clearly showed the head-to-head. PCI is the choice of therapy for reperfusion. So primary PCI, whenever possible, is the choice of reperfusion therapy in acute STEMI. There is no question about that. Now, then came the problem of that if a patient cannot reach a center offering him revascularization by PCI, what happens? And we know that in acute myocardial infarction, time is so very important. And like we say, time is muscle. And as time passes, the chances of the muscles, even if you open up the artery, surviving is low. So when time comes in, so if there is a delay, we today know that what we do is we thrombolize. But again, thrombolysis is not a destination therapy. So the thrombolysis needs to be followed up by primary PCI. So we have primary PCI on one side. If we cannot offer primary PCI, we go for pharmaco-invasive therapy, which means we thrombolize and then either send the patient to a center where we can do a primary PCI, or we quickly take up after maybe a couple of hours time. Now, this is a very bad time we are passing through. It's COVID time. And in COVID time, everything is delayed. Patient is delayed because patient symptom recognition is poor. Patient takes time to decide to go to hospital, is scared of the COVID, right? Even when he comes, there is slowing of the entire algorithm in hospital. See, in pre-COVID time, what our casualty medical officer hears that or takes an ECG, the ST elevation MI quickly goes to the cath lab, right? Today, he says I have some dyspepsia. He waits last in the queue in the ER where there are more serious patients, and probably recognition is late. And after the recognition is done, he has to have a COVID test done, because basically we want to protect our staff, and most of us don't have the luxury of more than one lab. So we have to protect our staff. We have to check for a COVID, or everybody has to have a protection within PPE kit and kind of stuff before they go. So there is delay. And when this delay comes in, question comes in that should we thrombolize? Okay, point number 2. And the third point that you take forward is that we know that COVID-related MIs are mostly thrombotic. So if you put it in a triangle, on one side, we have a best perfusion therapy is reperfusion by PCI. Second, we have a situation where there's a time delay and we have pharmaco-invasive therapy. And the third is a situation where we have so much of thrombus coming in the post-COVID scenario. So we will take all those as we discuss and go forward. So I think with that, we start the first talk, that is by Dr. Nigel Cletus, that is on STEMI in the cath lab. Dr. Nigel, you have about 15 minutes to talk about Nigel. We can about cath lab STEMI. We'll come back to you later on in the process of discussion where people can ask you doubts and we can also clarify things. So Dr. Nigel, STEMI in the cath lab in the COVID era, of course.
Thank you, sir. It's a great pleasure to be here today, sharing a platform with my senior colleagues, and thank you, Tani Nair sir. Thank you, my senior colleagues, Dr. Renju, Dr. Bino, and Sarjan sir. I'll straight away go to the presentation. I'll be talking about the management of STEMI in this pandemic era. So regarding STEMI management in the cath lab during COVID time. So as we all know, it is a very difficult situation that we are passing through. And we don't have set guidelines for most of the practices which we do. So we need to evolve a consensus on how to go about the management of patients during COVID-19. So the different problems that can arise are, first thing is the patient delays there. That is the lack of transportation. And then we have lockdown, different areas are placed as containment zones. Then the lack of routine medical services. And the patients are also scared for coming to hospital. So we also have so many patients who ignore their symptoms, or they come after the complications develop. So that is one problem we have. Second thing is there are the diagnostic problems are there. That is, abnormal troponin values can be seen among those with COVID-19 infections. And then even though we have a large number of centers for testing, the RT-PCR test, the reports we get only delay after a long delay. And in spite of, we also have a situation where in spite of testing negative, patients having COVID symptoms, so they should be treated as COVID patients. We should be taking the necessary precautions. So STEMI, as we all know, it has an inherent urgency and it has particular challenges. And in the presence of COVID-19, we have an enormous strain on the healthcare system. And
we can see your slides, Ratnaji. Can you share the slides? We can see the slides.
I have actually shared the screen. Can you see now? I'm sorry.
No. We can see you. No. You have to go to that green button, share the screen, and then make it into the.
Sorry. I'm sorry. Okay, I just shared, but I thought, okay. Is it now visible, sir?
Yeah.
It's visible. It's visible. You can go to full screen. Full screen. Yeah.
Full screen. Yeah, I know. Yes, I thought I'm sorry.
Okay. It's perfect now. Perfect.
Okay. Sorry about that. So now then cath labs also in general, they are not designed to isolate infection. So most of the cath labs they don't have a negative ventilation system, either normal or positive ventilation system. And also there is a high risk of staph exposure. So we need to, when we take up the patient, we need to weigh the balance between the exposure to the staph and the benefit. So we have a set of consensus set guidelines which have come. There is some ACC has there is an article that is reperfusion of STEMI in the COVID-19 era, business as usual. So here we have a flow chart. There is a STEMI patient. If the patient is a COVID-19 patient or a person who is thought to be COVID-19 patient and is under investigation. So if we have such a patient, then we go with the assessing of the cardiac risk. That is, look at the infarct-related artery location. Look if the patient is a high risk, that is having hypotension. Look at the Phillips class, any shock, arrhythmias, and then the presentation. And we weigh the risk-benefit against the potential risk of exposure going to the cath lab. And so if the patient is proven to be a negative patient or not a suspicious patient at risk for COVID-19, then proceed with primary PCI. And based on the cardiovascular risk, that is, if the patient is at a high cardiovascular risk, we directly take up the patient for a primary PCI and or a rescue PCI when after failed thrombolysis. And if it is a low cardiac risk, we go for a fibrinolytic therapy and administering a fibrin-specific agent. And then once after this reperfusion, then we transfer the patient to the isolation ward and then follow up. And then once the patient is found to be negative, the routine follow-up can be done, that is 2 to 24 hours. And the reperfusion is assessed by pain relief and the ST resolution more than 50%. And a consensus statement from SKY, ACC, and ACP, there is during the COVID-19 pandemic. Any patient who presents with ST elevation on ECG, and if the patient will do a ultra-rapid COVID-19 testing, and if the patient is COVID-19 positive, then and has symptoms consistent with MI and ECG features consistent with MI, and then do a point of care ultrasound to confirm wall motion abnormalities and diagnose STEMI and take up for primary PCI. If the patient has equivocal symptoms, ECG shows atypical features, then COVID-19 myocarditis should be considered. Always check serial ECGs, do a portable chest X-ray, and then come to a joint decision with regarding the CCL activation or whether to go for a coronary CT angiogram. And if the patient is a COVID-19 possible patient with symptoms consistent with MI, ECG consistent with MI, go for primary PCI. So the default, that is by primary PCI, should be remaining the default strategy in patients with clear evidence of STEMI. And in cases where we do not have a feasibility of PCI, we can consider a pharmacoinvasive approach. So now in a referral hospital, that is a non-PCI hospital also, we have the almost the same protocol, that is, if we have a COVID-19 positive or probable patient, then either primary PCI or or fibrinolysis and followed by a PCI. This should be done, that is 2 situations, that is either in a dedicated COVID-19 cath lab with the universal use of PPE and with special care for avoiding aerosolized and droplet precautions, and treat the patient in an ICU isolation bed. Then always in a patient with STEMI, the diagnosis of a COVID-19 myocarditis should be ruled out. And then at the point of presentation at the casualty, we should be evaluating for the symptoms of COVID also. That is, if a patient is at a high risk of COVID or having a high risk of chance of pneumonia, that might be a problem with taking up with the PCI, because the COVID-related morbidity might be high. And so conservative management might be better. So the next scenario is a COVID-19 possible patient in a non-COVID-19 cath lab. Again, always with the presence of universal use of PPE for aerosolized and droplet precautions, we should be taking up the patient. And the European Society guidance for the management, they have said that the maximum delay from STEMI diagnosis to reperfusion of 120 minutes should be remaining the goal for reperfusion therapy. And always primary PCI remains the therapy of choice if it is feasible within the time frame, and when it is performed in facilities which have a provision for treatment of the COVID-19 patients in a safe manner. So we have given a delay that is of up to 60 minutes. That is for the delay in because of the testing, and the delivery of care can be slightly delayed due to the COVID situation. So up to 60 minutes delay is acceptable. But if even within that time period, if a target time cannot be met, and if the patient is not at a contraindicated for fibrinolysis, always go for a fibrinolysis, and then take up the patient for a PCI based on the reports of COVID-19, I mean the diagnostic reports, and based on the patient's risk, that is whether it's a high risk STEMI or a low risk STEMI. So the ESC guidelines again, a patient with STEMI during COVID-19 pandemic, access to that is either self-presenting or ambulance. The patient comes to, that is transferred to hospitals with the cath lab service, and if there is a timely primary PCI available, take up for a primary PCI. If it cannot be done, go for fibrinolysis. And then in a non-hospital without a cath lab service also, if a patient cannot be shifted in time, that is even with up to 60 minutes delay during the COVID-19 time, go for a fibrinolysis. Otherwise can be shifted to a hospital with a cath lab and go for a primary PCI. And always any STEMI patient should be managed assuming the positive COVID-19 status in the situation with proper PPE, and the care should be done considering that the patient is always a COVID-19 patient. And then once the reports come, we can strategy, that is triage the patient according to the risk of the patient. And CSI has also made a document on the acute MI care during COVID-19 situation. And this was actually during March 2020. And that is before the COVID had become a pandemic in this proportion, that is a community spread had come. So at the time, the guidelines were based on this, that is screen every patient for history of international traveler contact. That was the time earlier. And then the assessing the respiratory status of the patient, then classify the patient of acute MI into 3 groups. That is one is the confirmed COVID-19 patient, then at the time rare in the community in India, that's what they have said. But then that is group A, confirmed COVID-19 patient. The second group is a suspected COVID-19 patient, that who is in a close contact of a COVID patient and has symptoms of fever. Then the third is a low clinical probability of a COVID-19 patient, group C, who does not have any symptoms, respiratory symptoms, no symptoms suggestive of COVID, and or a test is negative. So the both A and B groups are clubbed together. And then for a suspected patient or a confirmed case with no contraindications, thrombolysis is a prudent option. That is because if you don't have a provision of immediate reperfusion, that is immediate availability of cath lab, or if there is the non-availability of proper PPA protection, and then or if the patient is hemodynamically stable, then such patients can be managed with thrombolysis. In an unstable patient, the primary PCI would be an ideal option. And this, especially if the COVID-19 respiratory status is mild or moderate. If the patient does not have a significant pneumonia, maybe a chest X-ray and the assessment of the respiratory status and an X-ray might be useful. So thrombolysis should still be tried if the patient is an unstable patient, if there is any logistic problem regarding the diagnosis, testing and the availability of proper protection. So in those patients also thrombolysis can be tried, and then with a plan for a rescue PCI. So primary PCI should not be performed if we do not have adequate PPE, and preferably it should be performed in an isolated catheterization lab with minimum trained personnel to reduce nosocomial spread. And in the group C patients of STEMI, utilize the pre-COVID strategy, and we can go for thrombolysis if the inpatient service burden or the overall critical care, there's a high burden. Still, we can consider a thrombolysis and then go for a PCI based on the response. And in NSTB patient, if the patient is a stable patient, we can safely defer coronary angiogram or a PCI until we get a COVID-19 negative test. And then for confirmed or a suspected COVID-19 patient, thrombolysis should also be given in an isolated room. And in small areas, that is at the spokes in a hub and spoke model, thrombolysis should be the preferred strategy. And then the transfer of the patient, that should be discouraged to a maximum. That is, when we transfer the patient again, when we take up the patient at a cath lab facility hospital, there also the patient might have to undergo repeated testing. So the time delay might be more in this scenario. So thrombolysis and treatment of the patient in the hospital itself, or if the patient is stable, or if the patient is a high-risk patient with a large area of wall motion abnormalities or hemodynamic instability, then obviously they should be transferred for the PCI. Catheterization lab considerations during the COVID-19 pandemic from the ACC and SCI. So in STEMI patients, relatively stable patients, fibrinolysis can be a therapeutic option. And when primary PCI is performed in a STEMI patient, a person should be wearing PPE. And use of powered air purifying respirator is also reasonable. That is in particular in patients who require CPR or intubation, where the generation of aerosols is much high. And so in those patients, use of PAPR is advisable. And another consensus is that if the patient is at a high risk, that is respiratory status is bad, if we anticipate the patient might need might be a aerosol generating, that is more aerosol generation might be there, then and the respiratory status is bad, then it is always safer to intubate the patient before taking up the patient in the cath lab, so that the protection might be, we have a better protection. So this is a article from China, how to balance acute MI and COVID-19, the protocol from Sichuan Provincial People's Hospital. So again, they have almost the same protocol, that is STEMI patients with suspected or confirmed COVID-19 pneumonia. If they have a stable vitals and the onset is within the window period, then they can be taken up for a thrombolysis, that is in isolation ward. And if they have a good recanalization, then good ST resolution, continue the treatment and elective PC after recovery from the COVID-19 pneumonia. If the vital signs are not stable, if the patient has a severe pneumonia, then the patient, after recovery from the pneumonia, they should be taken up for a PCI. But if the patient is hemodynamically unstable and has either contraindication to thrombolysis or is a high-risk STEMI, then look for the benefit-risk ratio, and then if the benefits outweigh the benefits of taking up for a cath procedure outweigh the risk, then perform the protections under proper protection. You can take a patient for a PCA. So basically what to say, the stable patients can be treated with the thrombolysis, and unstable patients with severe pneumonia admit to the isolation ward. Unstable patients with mild to moderate pneumonia, we assess the onset of STEMI and follow the protocol as told. And for NSTEMI patients, there is it's not a critical, that door to balloon time is not critical. So first exclude COVID infection, and then once the patient recovers, should be assessed for further invasive treatment. This is regarding the protection, that is patient, all the PPA that should be applied, that is level 1 protection. The equipments like N95 respirator, disposable cap, gloves. Then level 2 protection, we should have goggles. Then the level 3 protection with the particulate respirator, disposable cap, shoe covers, and the aerosol generating procedures, or that is in if we suspect endotracheal intubation, then or any cardiovascular intervention, that is sputum induction, CPR, etc. is present, that is then extra care should be taken in this situation. And this is an article in the current cardiology reports in March 2021. So the key recommendations of different cardiology societies, that is, the patient should be initially evaluated in the emergency department with full healthcare worker PPA, and then primary PC is always the preferred strategy. And if a delay in PC is anticipated, go for a fibrinolytic therapy. CCL, I mean cardiac cath lab, a negative pressure room is preferred, but it is not always possible. Then the difference that is in if a PC cannot be performed within 120 minutes, go for a fibrinolytic therapy. Then ESC guidelines also almost the same consideration, that is all patients should be considered COVID positive and triage in the emergency department and take up for a fibrinolysis or PCI based on the presentation. So they are classified into 3 groups, that is a critically ill, STEMI or non-STEMI. They have a cardiogenic shock, hemodynamic instability, refractory heart failure, any mechanical complications, had a cardiac arrest. Those patients should be emergency taken up for a coronary angiogram. A non-critically ill STEMI patients, that is, if the patient, after they come to the emergency department, we do a rapid testing, antigen testing, and then we either they are antigen negative or we have a low suspicion of COVID-19 with suspected features of with ECG features of MI and high-risk features in non-invasive imaging. They should be taken up for primary PCI. And COVID-19 negative patients, antigen negative patients, or if we have a healthcare setting that is inadequate PP or any other logistical delay, consider fibrinolytic therapy. And non-critically ill NSTEMI patients, in low risk to moderate risk patients should be taken up based on ischemia guided strategy. High risk patients, again, they should be going for an invasive strategy. So the takeaway points are, there is a COVID-19 pandemic, definitely it's a medical emergency, which has not been seen before. So the risk to benefit ratio of PCI versus lytic therapy should be assessed. And in a situation where we have a delay in taking up the patient for a PCI, always go for thrombolysis. It is a prudent option. And then once we have a, after thrombolysis, assess the patient for the resolution of pain, look for a successful recanalization. Then based on the COVID status, we can take up the patient for either a pharmacoinvasive therapy, or they can be managed with medically. And in an NSTEMI patient, always check the COVID status, and patient can be taken up based on their risk score. And if there's a high risk patient, it should be taken up for a PCI. Otherwise, they can be managed medically. So this is regarding the PCI in a COVID situation.
Thank you, Dr. Nijal. That was an excellent coverage of the STEMI management in cath lab, and we clearly get a view of what you are trying to talk about. So we should take a decision depending on the risk that the STEMI patients have. Is he low risk or is he high risk, like cardiogenic shock, and take a decision on approaches, number one. Second thing is, do you have a single cath lab or multiple cath labs? Are you able to protect your staff sufficiently against COVID is the second factor. And the third, of course, the time delays that is built in and the kind of hospital that the patient first arrives. So very clear, you have put the perspective very clearly. So before we come back and all of us discuss the challenges, I would go to the next topic, which is pharmacoinvasive therapy, which the other diametric other end of the therapy. And to talk about pharmacoinvasive therapy, I invite Dr. Renju Kumar to talk about pharmacoinvasive therapy in this era of COVID for STEMI. Dr. Renju Kumar.
Thank you, sir, for this opportunity. It was an excellent talk, Nijal. Can you see this slide?
No, we can just see your desktop. You have to choose the Microsoft PowerPoint. Go unshare and go sharing again. Unshare, share again, and go to that Microsoft PowerPoint, not the desktop choice. Yeah, that's it. Yeah, absolutely.
Yeah.
Right.
So I will go to the straight away. I will go to the topic. The topic is known as pharmacoinvasive approach in STEMI management. We know that as an introduction, we know that the coronary artery disease is currently the most common non-communicable disease in India. And one of the gravest complications of CAD is STEMI. And reperfusion is a time-dependent key strategy in acute STEMI care. Though there are extensive, clear guidelines in STEMI management, there is a gap between the guidelines and implementation in clinical settings still exists. In India, the prevalence of STEMI is rising exponentially, leading to CV mortality and morbidity. Despite the advancement in reperfusion strategy, either pharmacological or interventional, the overall utilization of system of care and timely reperfusion remains suboptimal. We know that the reperfusion is the key strategy in STEMI, and we already discussed the PCA is the gold standard, and the next the option is thrombolysis. And we have to consider to bridge the gap, there is lysis followed by PCA, that is pharmacoinvasive. What are the challenges for STEMI system of care in India? The primary PCA is available to only less than 10% of STEMI patients in India. It's because of the lack of awareness, lack of transfer facilities, unavailability of the hospital with PCA facility. There could be delay from emergency department to the cath lab, either could be due to financial problems or obtaining a consent. Sometimes the cath lab may be occupied. Sometimes there is unavailability of cardiologists around the clock. And moreover, education is required for general practitioners and physicians to implement a early time-dependent STEMI management. And if you take the PCA strategies in STEMI, these are the terminologies. Primary PCA means PCA within 12 hours of symptom onset in a patient not receiving fibrinolysis. Rescue PCA, PCA mandated by persisting symptoms or persisting ST segment elevation. That means failure to achieve more than 50% of ST resolution within 90 minutes after the administration of fibrinolysis. Facilitated PCA, that means fibrinolysis followed by immediate PCA within 3 hours, irrespective of the fibrinolytic success. And the pharmacoinvasive PCA, fibrinolysis followed by routine elective early PCA, that means 3 to 24 hours of fibrinolytic administration. Today, our emphasis is pharmacoinvasive PCA, the immediate thrombolysis, and if possible, pre-hospital thrombolysis followed by a PCA within 3 to 12 hours. Since the PCA is performed after the early prothrombotic phase has subsided following lysis, it is claimed to have reduced chance of reocclusion and reduced rate of reinfarction. And it widens the time window for a PCA. Why this is important? See, if you take reperfusion utilization based on various Indian STEMI or bar ACS registries, the most extensive Indian registry evaluated a contemporary trend of STEMI management is CREATE registry and Kerala ACS registry. In CREATE registry, around more than 20,000 of the patients were analyzed, and the thrombolysis has been received by 58% of the patients, whereas PCA is received only in 8% of the patients. Both combined together solely around 60 to 70%. The reperfusion strategy is given only for around 60% of the patients. In Kerala ACS registry, it is done from 2007 to 2009. More than 25,000 of the patients were evaluated, and the thrombolysis was received in 41% of the patients, and the PCA was around done in 12%. If you take other registries also, the PCA is received only in 8 to 14% of the patients with an acute MI. And overall, if you take an Indian scenario, only approximately 50 to 60% of the patients with STEMI received thrombolysis or PCA in a time frame. So when you select a reperfusion strategy, timely reperfusion is important. There should be a better myocardial salvage and preservation of left ventricular function. We call it as time is muscle and muscle is life. So the right reperfusion strategy should be timely, effective, complete, safe, and easily accessible. For each 30-minute delay in the treatment of STEMI, the 1-year mortality increases by 7.5%. if you take the mortality benefit with primary PCA, it will be lost if PCA-related delay exceeds 60 minutes. Practically, early fibrinolytic therapy can compensate for PCA-related delay. So proportional mortality reduction was significantly higher in patients treated within 2 hours with fibrinolytic. Here comes the importance of pharmacoinvasive treatment. And if you take the selection of reperfusion strategy, we know that the gold standard is PCA, but the problem is, but it is less accessible. We know that especially in the Indian scenario, only 10 to 15% of the patients only receiving the gold standard treatment. Then comes the thrombolysis, which is less preferred but easily available, which is much more economical and has got various clinical studies has evaluated the success rates of thrombolysis. And when see even though thrombolysis has got good success rate, but the preferred one is gold standard is PCA. When you combine the thrombolysis with PCA, that means pharmacoinvasive. It is an attractive option, especially in Indian scenario, and it will bridges the gap. So what are the problems in Indian scenario? Already I had discussed few of these things. And nowadays, what we are facing more thing is like one is the transport delay, and few more things we are facing nowadays. Once one patient comes to your casualty and you diagnose the STEMI after an ECG, to tell the patient that it is STEMI, you have to go for an angioplasty or primary PCA. Then they will try to call a few other cardiologists or a few other centers, and getting too many opinions, which will delay the procedure or delay the favorable myocardial salvage time into 10 minutes, into 30 minutes, 60 minutes, even 90 minutes. And also, another newer problem is Google Doctor. Once the real doctor tells some opinion, they will consult with the Google and they will take their own opinion. And also, financial issues is also an important issue, but which we can still do with a fibrinolysis or some other way we can still solve. The most important problem nowadays we are facing is trying to get too many opinions and trying to get other opinions. It is appropriate for patients with STEMI who are eligible for treatment with fibrinolytic drug. You go for pharmacoinvasive if the transfer time is more than 30 minutes. From a first medical contact, if the transfer time is more than 30 minutes, I think we better to go for a pharmacoinvasive strategy. You utilize the patient. If the door to balloon time is more than 90 minutes because of either due to logistic issues in your hospital or logistic issues from the transport of the patient, or from the first medical contact to the balloon time more than 120 minutes, you preferably go for a pharmacoinvasive strategy. If you have a PCA-related delay, that means sometimes the cath lab is occupied, sometimes the cardiologist is not available, he may take more time to reach the hospital. So if the PCA-related delay is more than 60 minutes, then also you go for a pharmacoinvasive strategy. Because there are various trials has compared this pharmacoinvasive strategy with primary PCA strategy. And these trials have shown that the pharmacoinvasive strategy is a good alternative if there is a delay. These are the trials: STEP AMA, STREAM, NORD-STEMI, Transfer AMA, Burst Capital AMA. All these are evaluated, and most of these trials have used tenecteplase as the diuretic agent, and they had shown that the pharmacoinvasive strategy is as good as primary PCA strategy if there is a time delay. This is an observational multi-center study, STEP AMA, and this is done in South India, and 5 primary PCA capable centers has been involved in this study, and they are divided into 2 groups. One is pharmacoinvasive strategy with tenecteplase. The numbers is only 45, whereas primary PCA received in 155. Total number is 200. And the primary endpoint was composite of death, cardiac shock, reinfarction with revascularization at 30 days. And the study shows that to take this pharmacoinvasive group and the primary PCA group, if you take this 30 days and 1 year the total event rates or the primary endpoints, it's 13.3% in pharmacoinvasive compared to the 9%, which is not statistically significant at 1 year. So the pharmacoinvasive strategy can be implemented in patients not selected for primary PCA, especially in Indian scenario, and it hints the possibility of similar outcomes. And this study, this STEP AMA trial, has been extended. This is extended for 2 years, and this observational study at 2 years has shown that at the end of 2 years, like 24 weeks, 24 months, there is not much difference in the survival distribution between the two groups over a period of 2 years. So, in conclusion, pharmacoinvasive strategy resulted in outcomes that were comparable with primary PCA at 2 years, suggesting that it might be a viable option, especially in India. But larger studies should be required to confirm these findings. And this is also an observational study, and which is compared this pharmacoinvasive with primary PCA. This is 138 patients were included. In this pharmacoinvasive strategy, they had used streptokinase. It is a single center cover over a period of 9 months. And in this also, when you compare the primary PCA and pharmacoinvasive group, and the primary endpoint was 11.6% in pharmacoinvasive arm compared to the primary PCA arm, which is not a statistically significant difference. So at 1 month follow-up, the incident rate for primary endpoints was 5 events per 43 patients. That means 11.6% in pharmacoinvasive and 18 events per 95. That means 18.9% in primary PCA. So pharmacoinvasive strategies is a good option compared to the primary PCA in STEMI in specific scenarios. This is a meta-analysis, and this meta-analysis compared primary PCA with pharmacoinvasive trichomonogy in transfer patients with STEMI. And there are 17 studies were included in this meta-analysis. Of which 6 were randomized trials and 11 were observation studies. Almost more than 13,000 patients were there in this study. And in this trial also, in this meta-analysis also, overall there is no significant difference in short-term mortality, whereas the pharmacoinvasive strategy significantly decreased the short-term mortality in those studies with a symptom onset to device time more than 200 minutes. That means the pharmacoinvasive strategy has an advantage if there is a delay in the primary PCA. So in sum up, timely intervention to revascularize the occluded coronary artery is the mainstay of treatment for patients with STEMI and should be achieved ideally as soon as possible. Delays in primary PCA can result in increased mortality and morbidity. Pharmacoinvasive therapy using a third generation LIT can be a critical repercussion strategy in many patients who are present to a PCA center where delay in primary PCA is anticipated. It can be a life-saving option for patients presenting to a non-PCA center and in those living in rural and semi-urban regions. And another entity we have to be discussed is immediate PCA or facilitated PCA. This has failed in various trials as evaluated, especially Finnish trial has definitely shown that this facilitated PCA, that means if you're lysing a patient and taking up the patient immediately along after the lysis, and there is a higher mortality and higher risk of bleeding. And this is within 3 hours, you are taking up the patients. And most of this facilitated PCA, you had taken half dose of Lytic and half dose, and you had added a GP2 inhibitor also. So there is an increased bleeding risk. Also, there is paradoxically, there is increasing the ischemic endpoints also because of the higher prothrombotic milieu during the immediate lysis period. So when you consider the pharmacoinvasive strategy, which thrombolytic agent should be ideal? And we know that we have different thrombolytic agents, but we should have a ideal thrombolytic agent should have an easy administrating agent. the onset of action should be fast, and it should be safe, it should be effective, it should be there should be a cost benefit ratio, and there should be ample real world evidences for such a good molecule. All these key attributes should be considered when you select a thrombolytic agent, when you consider for a pharmacoinvasive strategy. We know there are certain thrombolytic agents. We know tenecteplase, the dose is 0.53 milligram per kilogram, single bolus over 5 seconds, and the level of evidence is 1A. Retiplase, you use 10 unit, 30-minute interval, 2 bolus doses, and the level of evidence is grade 1B. And altiplase, 50 milligram IV bolus followed by 0.75 milligram per kilogram over 30 minutes, and then for 0.5 milligram per kilogram over 60 minutes, and the level of evidence is C, grade 1C. And the disadvantage with retiplase and altiplase, and this is not a bolus, that means there are time, you are taking more time when you are giving a lytic agent. And the streptokinase is also the same scenario, and you are using 1.5 million units over 30 to 60 minutes. The level of evidence is grade 2B. For streptokinase, the only problem is to perform a PCA, you have to wait for at least 12 hours, 6 to 12 hours, and you cannot take up the patient immediately, like after 3 hours or 4 hours. And the radial approach is always the preferred route in pharmacoinvasive therapy to avoid the complications through the femoral route. When you consider the thrombolytic agents about streptokinase, and various trials have shown that there's two evidences, and this evidence shows that the success rate of streptokinase is only 45%, and whereas the failure rate is 55% in one data. In another data, it was 54%, the success rate of streptokinase. So the problem with the streptokinase, only almost 50% is the success rate for streptokinase, but it is much more economical and cheap. So, but what are the disadvantages when you consider streptokinase compared to other agents? This streptokinase, the most important, is not a fibrin-specific agent, and the fibrin specificity has got a very important role in the fibrinolysis. We need fibrinolysis rather than thrombolysis. Should be fibrinolysis. And another thing is there is resistance to PI1. There is no resistance for streptokinase to PI1, but the PI1 resistance is there for tenecteplase, which is the advantage over other molecules. And when you systemic fibrinogen depletion, there is a minimal systemic fibrinogen depletion with the tenecteplase. All these factors tell you that the tenecteplase is the better molecule for a pharmacoinvasive strategy. And when you take the time, and this is an algorithm which had shown the time factor, and when you diagnose a patient with STEMI, the first medical contact, you are taking an ECG, and if that is the 0 point, the time starts there, 0. Once you diagnose the STEMI as, with an ECG, within 10 minutes, ideally within 10 minutes, you should give the fibrinolytic agent if the patient is planned for a pharmacoinvasive. But if patient is planned for a PCA, you have still, there is a time gap of 60 to 90 minutes. You transfer to a PCA center if it's possible within the maximum time period of 120 minutes. If you can get a PCA facility, then you can still go for the primary PCA as the technique. If you are otherwise, if you are in a primary PCA facility, if it takes 0 as the ECG time, within 90 minutes, you should do the balloon. It's wire crossing and balloon. Now it is considered wire crossing, not only balloon. So it is considered should be 90 minutes should be the target time, maximum time. So in fibrinolytic strategy, the goal is to inject the bolus of fibrinolytic as early as possible once the STEMI is diagnosed. And it should be a bolus dose. That is why the tenecteplase is preferred. And if you want to transfer to another facility for a pharmacoinvasive within 3 hours, and better you use a fast-acting molecule like tenecteplase. The problem with reteplase and other molecules, it is taking more time for the reperfusion. And this is one analysis. It's an Indian data, and Tiny Nairs also is a key instrumental in this evaluation. And it's a data from 15,000, more than 15,000 patients, and it's collected from 1,152 cardiologists, more than 700 centers across India. In this trial, the overall the efficacy of tenecteplase is 95.43%. The reperfusion data in less than 3 hours, if the patient has reached given the molecule with less than 3 hours, it is 96%, and 3 to 6 hours, still it is 96%. But if it is more than 6 hours, the success rate of thrombolysis is, with the tenecteplase is 85%. And this is another data. It's in more than 7,000 patients. It's a real world Indian experience. SAR is also, Tiny Nairs is also instrumental in this observational study. And in this study, the overall rate of achieving the comprehensive, the reperfusion strategy, 93% of the patients, 93% of the patient has got a chest pain resolution. 91% of the patient had a 50% resolution of ST segment at 90 minutes. And the 53 patient overall in this analysis, 53 patient died. The mortality was only 0.69% before discharge. And if you take the safety endpoints, the incidence of bleeding was 1.7%, excluding stroke. And the overall stroke incidence was 0.18%. The intracranial hemorrhage was only 0.38% in this observation study. In conclusion, the study reinforced the safety and efficacy of indigenous tenecteplase in Indian patients presenting with STEMI, including high-risk subgroups. So this is the in nutshell about the reperfusion strategy in STEMI. STEMI, once it is diagnosed, primary PCI capable center should do the primary PCI, and the time should be less than 60 minutes. The wire crossing should be less than 90, maximum time is less than 90 minutes. If the patient, it's not a primary PCI capable center, the transfer time is less than 120 minutes, then still you go for primary PCI. If the time delay is more than 120 minutes, you go for a pharmacoinvasive strategy, do a fibrinolysis, and transfer the patient to immediately to the PCI capable center. If there is a reperfusion as evidenced by the analysis, then you can preferably post this patient for a pharmacoinvasive strategy. If the patient doesn't have a good reperfusion, the patient can be taken up for a rescue PCI. And this is basically, this is the pharmacoinvasive strategy in Indian scenario. And this is, you can, in the COVID era, already the guideline has been discussed by the Dr. Nijil. And I think in this pandemic era, there is no urgency in a pandemic. You have to take you have to take care of you. You have to take care of your colleagues. You have to take care of a cath lab personnel. Most of our institutions have only one cath lab, and which is also we are taking all type of cases in such labs. So you have to be judicial when you consider a PCI in an acute MI situation, especially in a COVID positive timing. I think the better strategy in one cath lab scenario, better is go for a pharmacoinvasive, because a lot of time delay happens from the casualty to the ICU to the cath lab. So better to go for a pharmacoinvasive strategy based on the proper guidelines. Thank you.
Thank you so much, Dr. Ranju, for that excellent coverage on pharmacoinvasive. You had excellent coverage. So at this point, I would welcome Dr. Sajan and Dr. Binu, our panelists also, so that we would like to hear from them. So I think the question here is, on one side, we have PCI, primary PCI, and all of us who are in invasive cardiology, we know that how good primary PCI is in a STEMI, right? A STEMI patient comes with severe chest pain, LV dysfunction, he is slightly breathless. The moment the wire crosses, you get the flow on, you might get some arrhythmias, but quickly things settle down, and the moment he comes out of the cath lab, he's pain-free and settled, So it is an excellent procedure, and all of us wish that if we can give that procedure somehow to a STEMI patient, it is the best, right? But like Dr. Renju had shown beautifully in his slide of that humorous slide on delay, like Google doctor and multiple opinions, and people don't understand. I've read in newspaper that unnecessary angioplasties are done, and we are stuck. And you feel so frustrated that what is this happening? You tell that, see, he will recover. That's a doctor. Can I take an opinion? My brother-in-law, father-in-law is a doctor. Can I call him up and all that? Do you think I'm seeing this doctor regularly? Should I call him up and all that? Can we wait till tomorrow morning? You feel so frustrated. And at that point of time, we got COVID, right? COVID has created a huge big problem whereby it's a problem for our staff. So in that background, between PCI and thrombolysis, obviously when we are talking about thrombolysis, we are talking about pharmacoinvasive therapy. What would be your take before we take up other nitty-gritty of which agent to choose and all that? Dr. Sajan, would you start?
Yeah.
Yeah.
Yes. Thank you. Good evening, Dr. Tiny sir and MQR people. See, a couple of points. I agree with all which has been mentioned, because we are going through a pandemic phase, and also people arrive late. So I was also referring all these.
Hello.
Topics which have been forwarded. So I see this is one of the very important options. Am I audible? Hello?
Yeah. In between the audio got dropped.
Pharmacoinvasive is a very attractive option, primarily because most of the centers, especially during triple lockdown and lockdown, we are faced with a shortage of cath lab staff, cath lab nurses. So then there is a delay in arranging all this stuff. So a couple of things which I wanted to highlight. One is first of all the diagnosis of fistulation. It's a little tricky in the context of COVID, because see, we have one case series which was published in New England Journal of Medicine by Sripal. I think you must have gone through that. Sripal, Bangalore. Out of 18 cases of patients, 18 cases of COVID positive with ST elevation, 10 had no coronary obstruction on angiogram. Only 8 had coronary obstruction. So that's a challenge which we are facing. How to diagnose the ST elevation MI, which is due to type 1 MI, according to our diagnosis, correctly in COVID situation. Because if you incorrectly diagnose type 1 MI and administer thrombolysis, then I think it can be counterproductive. So some guidelines, especially some operators or some investigators have suggested that you can use a cluster of signs and symptoms, like go through the patient's signs and symptoms. If the person is overtly COVID positive with the COVID symptoms like pneumonia and sepsis, then it can be either type 1 or it can be type 2 MI. For example, if the person is just a COVID positive patient that is suspected or just COVID positive without any classical signs and symptoms, then the chances that it's a type 1 MI is much more. Then a point of care ultrasound, a quick echocardiogram, which if we can arrange in the emergency department, is very helpful, because if that echo is showing a regional wall motion abnormality in specific territory, then I think it is more suggestive of type 1 MI. Although I agree that there can be a situation where type MI can also present with the regional wall motion abnormality, but considering all these points together, we can reliably diagnose type 1 MI and go ahead with the treatment strategies. So that's one. But most of the guidelines are very clear that if the perceived delay, that is first medical contact to the primary PCI, if the perceived delay is more than 120 minutes, then we should go for administration of thrombolysis. And thrombolysis is especially if you can administer as a pre-hospital phase, then it is associated with a very good outcome. We have some abundant data, especially when you most of the data which Dr. Renju showed that there is some increase in hemorrhagic stroke with the pharmacoinvasive. That is because that didn't include analysis of STREAM trial, which had modified the dose according to the age. If the age is more than 75, they recommend to give half dose of tenecteplase, and you have to omit the intravenous dose of enoxaparin in such situations and reduce it to start with a subcutaneous dose of enoxaparin with 0.75 milligram per kilogram. If you do that, then the incidence of intracranial bleed is almost comparable to the primary PCI arm. So I think most of the studies which you have showed that increased incidence of hemorrhagic stroke is because those studies did not consider the dose modification according to renal patch, which is very important factors. That's all from my side. I think I'll have to hear the opinion of Dr. Bino also.
Yeah, Dr. Bino, what would be your take on this point first, that between PCI and thrombolysis in this era of COVID, what are your concerns and challenges here? Please tell us.
Yeah, so I totally agree with both the speakers and as well as Dr. Sajan. I totally agree. In this situation, if you consider the well-being of the patient, the best would be to go for primary PCI, no doubt about that. Best benefit you get with that. But you have to consider your colleagues, the risk of your colleagues, the risk of your cath lab staff, CCU staff. In that case, you have to risk stratify these patients. In those patients who are low risk STEMI, in those patients, particularly if you have only one cath lab, then you may opt those patients for thrombolytic therapy and later for facilitated PCI when the result of COVID is available. But in those patients who are high risk, definitely those patients who have, as Nigel has described, those patients who are high risk with Philip class 3 or 4, hypertension, arrhythmia, all those things. In their case, definitely you have to take the risk and go for primary PC. One more thing, what I feel is if you're going for facilitated PCI for thrombolysis, what I feel is in that patient who is going for thrombolytic and then for facilitated PCI, the total duration of CCU stay is much more for this patient. For those patients who are COVID positive, you are going for thrombolytic therapy, then those patients to get stabilized, it will take more time, longer time when you compare with a patient who has undergone primary PCI. So the exposure for your CCU staff is also much more. Not only that, these patients, many of the time, they may have recurrence of angina. They may not hemodynamically settle. So longer hospital stay, longer CCU stay. So again, that's also one problem for the patient as well as you are exposing your CCU staff. In my hospital, the scenario is a bit different. We have 2 cath labs. So we straight away, in all patients with STEMI, we offer primary PCI. And only in those patients, if there is a confusion, in that case only, and most of the patients with STEMI will not come with a positive report. So all STEMI patients, we consider them as a possible COVID positive patient and offer primary PCI. And if they are willing, just one extra 5 minutes to take the swab. We don't wait for the report, take them for primary PCI and go ahead. That's the usual practice in our hospital.
Yeah, thank you, Dr. Bino. So I agree fully with you. So what we learned, I think we are here. Number one, when the patient comes, like Dr. Sajan said, we first have to decide if it can type 1 MI or a type 2 MI, right? So if this patient is, see, this is a scenario where we tell everybody that whoever you are meeting, whether your friend or your parents or your patients or whoever, you take them as possible, probable COVID, right? Today, that's an era. Everybody is likely to have COVID. Now, a patient comes and then we see that he has no signs and symptoms of COVID. He looks otherwise fine. And we take an ECG and ST elevation. So we suppose he's type 1 MI. So the primary MI, and we suspect that there's a coronary blockage. And we also know that the best option in front of us is PCI, right? And then we risk stratify. That's the second thing. We see that if he's very high risk, obviously all of us will say go for PCI. If he's lower risk, then again choice. If you are lucky like Dr. Bino to have 2 cath labs, the problem is solved. You send your positive patient or undiagnosed patient plus minus to the cath lab where you can straight do and then wait for the report. But unfortunately, most Kerala cath labs, hospitals, have just 1 cath lab, right? Now, there the challenge comes in. I will tell you a practical scenario. Morning, let's say our cath lab. Morning, 5 patients are posted. Now patient numbers are less. Let's say 5 patients are posted. They have come, got admitted, everything ready. 3 are waiting just before the cath room. Okay, 1 is inside the cath lab and 2 are waiting in that waiting area to come into that. Now then suddenly a call comes from the ER that, sir, there's a patient who is acute MI. We see, oh my God, V1, V2, V3, or ST elevation, right? So reflex, he needs PCI. Send immediately to. Now the casualty officer would send a RAT maybe, but RAT may be negative, still he will be positive. Now the question comes in, if we take this, not just the staff, not just the question of operator, but your whole system of care gets upside down, right? These 3 patients waiting, Now, can we confidently send after the, normally what we say, you wait here, there's a heart attack coming in, right? Wait, everybody wait. And then how can I send the next patient in? Because, cath lab is already was occupied a little while before. And in Kerala, everybody knows what is that patient, is new patient, is he positive? Everybody is talking. So that puts all our system of care into a topsy-turvy. So many of our hospitals now, we are thinking that, okay, if we have a kind of patient who is not in cardiogenic shock and he is not kind of dying, why not in the ER thrombolize and then see when the cath lab is empty in the middle of the night, that's not an issue at all. Okay, so that becomes a challenge. So in that background, any one of our panelists or our speakers, do you have an opinion or what is your take on that? I think that is more practical, because if you remember, Dr. P.P. Mohanan had showed a map and a data, and that very clearly showed in Kerala, the actual time taken for a patient if he wants to reach a cath lab, other than the northern districts in Kerala, is not very great. See, Cochin, Trivandrum, like before 15 minutes, they can be in a hospital with cath lab, right? So if the patient is willing and everything is ready, reaching a cath lab enabled hospital in Kerala is the easiest compared to any other place. Now that is not a problem. Once they come in, it is our problem as to how we handle it. So what is general opinion of everyone?
So one important challenge in suggesting a patient with a suspected COVID. Actually, when you call a patient as a suspected COVID, there are 3 points. One is when the person is coming from a containment area, or a person who has been coming from an area where it has been declared as a containment area for the last 14 days, or a person who is directly involved in the care of a COVID positive patient. So these are our patient who has symptoms, but COVID results are not symptoms are typical of COVID, but the results are not available. This is what is called suspect or high risk, high chance of high probability of having a positive COVID patient who presents with a, say it's a type 1 MI. Now the problem which are faced with a low resource setting, like in my center at least, the thing is that the center allows you to do a primary PCI for this patient. But the problem is that the person has to pay for the, not only for the primary PCI charges, but also for the cath lab desanitization after the procedure, which is a huge thing. And most of the things which cannot be reused for this patient, because most of them will be disposed. And also then they have to pay for the personal protection kit of not only the doctors, but also the cath lab technician, the staff involved. So the cost actually multiplies for an individual patient. If he's covered by insurance, that's well and good. But the problem is that if it is not covered by the insurance, then the cost for the primary PCI is different in such situation when compared to, say, when we were suggesting for a COVID negative patient. Because and also this person will be going to an isolation room, and once the staff nurse will be posted 24 hours, 3 staff nurses will be posted at 8 hours intervals, and at least this person has to be in hospital for at least 48 hours. And if it's an anti-viral MI or cardiogenic shock, then he has to be not more and be nursed in a separate setup, and then that escalates the cost. So that is a very important thing which we have to disclose to the patient before suggesting the possibility of primary PCI. So in such situations, what we do is it takes time, because even in some senior operators used to tell that in India it is not door to balloon and door to needle, we have D to M, door to money time also. So this prolongs the door to money time. So that D to M time is prolonged. So then such situation, thrombolysis is a very attractive option, especially if it's a single bolus connector place. Then we can do that, and if we can open up the vessel, if the person is stabilized, then it gives some time for the patient to take a decision and then proceed. That's what we do in our center, where we have only one cath lab.
But the problem is, see, the moment you add a connective place, the cost immediately goes up. I mean, of course, the PP cost and all is there. But the moment you thrombolize, so what happens is that the same patient's relatives come and say, sir, my uncle had an angioplasty done last year. It cost only this much. And my nephew, it is now another addition of 50,000 rupees. We had to tell him, see, we have given him Elaxim. We had, there was no way because this is COVID time and all that. So I think what you said is absolutely right. Dr. Nijal or Dr. Renju, do you have any comments to make on that background as to practical? We are now not talking about slides, not talking about thrombolysis or PCI versus pharmacoinvasive, but practically down in our cath lab, sitting in the hospital when a patient comes, how would be your take to tell the patient what to do? You get the call from ER in the morning, 10 o'clock, with the 2 of your patients waiting for routine cath. telling that an ST elevation has come. The patient is otherwise stable, but you see it's an anterior wall MI, and they have done an echo and they said there's RWMA. The rat is sent and not yet come. What would be your take on that?
Sir,
Yeah.
definitely in my center, actually, I have a blessing in disguise that it is a low volume center. So we don't have this many patients waiting.
Now every center is low volume, don't worry.
So the strategy which we follow in a hospital, that is when they come itself, once STEMI is diagnosed, do a rapid antigen test, and then immediately, because it's like for so long time we have been under this COVID-19, so it's almost streamlined kind of. That is the staff there already prepared with PPE, and shift the patient if it is a high risk case, then definitely take up, and we don't have, most of the time don't have cases waiting. So then once the report comes, till then, I mean, we keep the patient in an isolation room, and then shift to, if it is a positive case, then we shift to COVID ICU, or when if comes negative, then shift to CCU, and that is the way we manage. And the cost issues are, I feel, if they have decided for a PCI, then the additional cost also they are most likely to ready to bear. They decide for PCI. Otherwise, because the thrombolysis versus PCI was the issue we had even pre-COVID, and that continues. That is what I feel in my situation.
Yeah.
So
Yeah,
from
Dr.
my
Ranjit?
side, sir, what I consider is that now present this second wave, we can't say that every patient should be equally considered as COVID positive unless otherwise proved. Because you cannot say it is contained everywhere, it is there. So you cannot differentiate a patient. So what we follow is when the patient comes to the ER and the patient has purely cardiac symptoms, there is no fever, no respiratory symptoms, purely cardiac, chest pain, and classical presentation, ST elevation MA, we do a rapid antigen test. If the antigen is negative, we take up the patient to the cath lab with all personal protective measures, and we do the primary. After the primary, we'll shift. We have the common ICU. Like that means whatever the emergency patient coming, which is antigen negative, RT-PCR has sent. Those patients will be in a common ICU, and then they will go to the designated ICU. What RT-PCR comes as positive, they will go to the COVID ICU, and the RT-PCR is negative, they will come back to the coronary ICU. So in a classical presentation, without any fever, without any first primary contacts, like household members doesn't have any primary contact, we are taking up for primary PC with standard precautions. But if there is, we had with this approach, we had landed in trouble in several times, because we had done the PCI after the 24 hours, the patient result came as RT-PCR positive. So nothing can be done. 3 or 4 hour cath lab staff has developed COVID. Luckily, cardiologist does anyway, it's not luck, but probably the time factor we have not received. But it is a risk we are taking up. Once the patient has some features of COVID, some fever or some, then we will prefer for a fibrinolysis. That is what we used to do.
Yeah, I agree that, so that is a kind of, I think all of us move in the same line. As long as we don't have the luxury of having 2 cath labs, we now know as to how to proceed. That is point number 1. Now, can we shift on to something else? See, even before COVID, we used to always say that whenever we get a patient, we get a lot of patients who are thrombolized and then sent for PCI to our center, because we are very close to Tamil Nadu border. And in Tamil Nadu, bordering to Trivandrum, we get a lot of patients who go there with MI, they're thrombolized with TNK, tenecteplase, and sent to us. And when they're thrombolized, we do an angiogram. We very rarely see a totally occluded artery. So, tenecteplase is really, really good in practical terms, right? Now, that question comes in that today we also have reteplase there. And the data has been shown that reteplase and alteplase needs a longer period of time to go in. So that very benefit of tenecteplase being just 1 injection is not there with the other thrombolytic agents. So what is the panel's opinion regarding choosing an thrombolytic agent? Because I see some of the hospitals now do stock only Retiplace. Okay, and Retiplace has a lot of advertisement now, and people stock that. So what would be your take home or an opinion on Retiplace versus Tenecteplase in this background of COVID, when we are so much of constrained about time? Our opinion is very clear. We all use only Tenecteplase. What is the general opinion from both our speakers and panelists?
So in
You can start,
hospital,
yeah.
As far as efficacy is concerned, I feel Retiplase and Tenecteplase both are of almost same. Both are efficacious, much better than streptokinase. But if money is not a concern, looking at the ease of administration, I would prefer Tenecteplase because single bolus, it's very easy and works well. But Retiplase, you may need double bolus. It's a bit complicated when compared to Tenecteplase, but the advantage is it's cheaper. So if cost is not a concern, I definitely prefer Alaxim. If cost is a concern, but you want the most efficacious one, then go for Retiplase.
Actually,
Sajan,
now,
yeah.
I use Alaxim.
Yeah, actually, see, actually the guidelines, if you go by the guidelines, it doesn't make a distinction between all the three, that is Retiplase, Tenecteplase, and this thing. For the recent latest European Society of Cardiology guidelines mentioned that if you are planning pre-hospital thrombolysis, Tenecteplase may be preferred because it is because of ease of administration. But if you are a purist and if you go by real data, see the data which says that which actually proved the efficacy of Tenecteplase was ASCENT-2 trial, which actually was a head-to-head comparison with Alteplase. So that showed that Tenecteplase is equally efficacious, and also it is associated with lesser intracranial hemorrhage. Same intracranial hemorrhage, but lesser non-intracranial hemorrhage. But when you compare the same thing with Retiplase, which actually compared between with the Alteplase in GUSTO-3, actually Retiplase didn't reduce the mortality when compared to Alteplase, front-loaded Alteplase. So there is no head-to-head comparison between Retiplase and Tenecteplase. But when you go by the indirect comparison, that is when you compare the data from GUSTO-3 and ASCENT-2 trial, the Tenecteplase may be slightly superior, and especially if you are planning a pre-hospital thrombolysis, it's very easy to administration. The Retiplase, we have to wait for another half an hour for administration of the second dose. So these are things which are logistics which are concerning. But efficiency wise, I don't think that there is any data which shows that one is superior to other. But considering all the other logistics, single bolus may be slightly better because it doesn't need any supervision of a cardiologist also, because you can, if an emergency physician is very experienced enough, and if the ECG opinion can be given over WhatsApp by the cardiologist, then that can be administered on the ER itself, the single bolus.
Yeah, Dr. Nijal or Dr. Ranju, any opinion on that? Choosing a thrombolytic agent in this era, any difference of opinion or anything to add?
Basically, in this era, basically it's an era of interventional, most of the interventional things. So there is no isolated thrombolysis as such. So most of the patients receiving a fibrinolysis is going for a PCA as early as possible. So in this, if you consider this pharmacoinvasive approach, I think the Tenecteplase should be preferred. Otherwise, if you take like trial data, like all these three molecules are good enough. But in a pharmacoinvasive approach, I think Tenecteplase should be preferred.
No,
that was the preferred agent in STREAM trial, which is one of the very latest trials. STREAM trial.
See, we should understand that the whole picture has changed. See, at one point, let's say before COVID, we were talking about Tenecteplase being given one in a smaller hospital where there is no cath lab, right? They put Tenecteplase, settle the patient, and transport. That is one. Second, we were talking about pre-hospital, like you said. Like in ambulance, like so. If the ambulance thrombolysis doesn't exist in Kerala or anywhere in India, I mean, rarely maybe Escorts Heart Center might do it, but it is incidental, right? It's not a common thing to happen. Number two. So now suddenly we see there's a change in scenario whereby the thrombolysis with Tenecteplase is happening in our own ER, right? Where because it comes at a time when there are other patients waiting, or patients don't have a diagnosis, or there is RAT positive, or RAT is not available, so they are thrombolyzed. So I think there's a total change in scenario, and that is the very reason why we are again sitting and talking about thrombolysis. Otherwise, the question would come: why should we talk about thrombolysis in Kerala, where we have what we have? Let's say the BMJ says that you need about, I think, three to 5 cath labs for 1 million people, and for 0.75 million in Trivandrum, we have what, 17 cath labs. So I think we have an overdose of cath labs. And if you're not careful, you would land up in a cath lab. So there, why should we discuss thrombolysis at all? Because this is for benefit of Dr. Omkar Swami, who is also listening. In Kerala, there is a change in situation whereby now we are talking about our care for our staff, and not only the care for the patient and avoiding a delay. So there is a new opening that has come up. So I think we are already late and it's 8:20. So I would request each one of you, starting with our speakers, can you give one take-home message for the listeners before we end this session? Because we had promised Dr. Omkar will end at 8:15. It's already 8:20. So starting with Dr. Ranju.
But it was pleasure, sir. It was pleasure discuss and listening all these things.
Yeah.
But I just have one question, sir. Maybe
Yes,
because of tinectipes is a single administration, we are not exposing our staff to the undiagnosed patient of COVID, and may not be exposed that patient into ER. That's the question.
True,
So
less
do you
patient
think any
contact.
merit?
Yeah, yes, absolutely. See, today we are talking about whatever minimum interaction with the patient and the health staff is needed. But see, the point is, if you are talking about, let's say, our ER or any of our ER, where the nurse is in PPE kit, right? Where she is like treating every patient as potential COVID who comes to the ER. And in that side room of ER, we have the first segregation unit, where if the patient is thrombolized, there we have monitors and it goes there. There every staff is in PPE. So probably it is not a situation where an unprotected staff treats the patient. So patient in PPE, a sister is there in PPE who takes just about 6 hours duty. And so for her, giving 1 injection or 2 injections may not be an important thing, unlike in a smaller hospital where the staff may not be protected, but it is an important point. So Dr. Ranju, what would be your final take home for the people who are listening at large?
Yeah, my final take home message is primary PCA is the gold standard for acute ST elevation MA treatment. But in this COVID era, we should consider pharmacoinvasive strategy also and a preferred method, especially in suspected COVID patients presenting with STEMI. That is my final take home message.
Nigel?
What I would like to say is, in this particular situation, always assess the patient if he's a high-risk MI, that is having high-risk features, then always it is better to go for a primary PCI. But in our initial evaluation, if we find it is a low-risk MI, pharmacoinvasive approach, definitely it can be done in this current situation, which gives us more time. And once the diagnosis comes, it helps in avoiding the infection and keeps our staff also safe from this pandemic.
Sajan?
Actually, see, I don't have much to add to the two statements which have been put forth. Only thing is that the correct diagnosis in the current COVID era is very important. And I cannot overstress on the importance of a good echocardiogram on the bedside, because we are seeing a lot of STEMI mimics. And in such situations, the STEMI mimics, where it's not our clinical acumen may not be able to differentiate a STEMI mimic reliably, but still we should strive for accurate diagnosis of type 1 MI before embarking on any further management. Because if it's an improper diagnosis, we may give thrombolysis for a person with a Takotsubo or a myocarditis, or if you are not careful, you may take the patient with the COVID positive diagnosis to cath lab and infect everyone there. So the accurate diagnosis at emergency room or in the triage room is very important before embarking on further risk stratification.
Yeah, I'll sum up all the three previous speakers. I would sum up that in center with 2 cath lab, gold standard, go for primary PCA. In center with 1 cath lab, risk stratify, high risk, go for primary PCA, low risk, go for facilitated PCA. That's all.
So I think I can't see any question, Dr. Omkar, coming up in the chat box. So I presume
Yes,
that
sir.
probably no questions are there. But I think what I have learned from this symposium, I will tell you in just 3 sentences. Point number 1, like has been highlighted very clearly, we should be careful about the MI mimics when we first see a patient. In the COVID era, just an ST elevation or a troponin positivity does not mean an MI. So we need to basically differentiate between, like Dr. Sajan said, between type 1 MI and type 2 MI. Type 1 MI is the standard MI, which is an MI because of blockage of an epicardial coronary artery, comes with an ST elevation, troponin high and all that. And that patient has no symptom of COVID, right? That is one end. He might test positive accidentally, that is different. And the other end would be a patient who has come with florid pneumonia and COVID and is already in your ICU, in the medical ICU, and suddenly develops an ST elevation. That is different. So when we are talking about a type 1 MI, then we look into his risk. Okay, is he high risk or is he low risk? Okay, because if he is high risk, our preference would be, if somehow possible, we should take him up immediately for a primary PCI. Not that low risk we don't want to, but we can still wait, right? So high risk, like cardiogenic shock or an MR or a major arrhythmia or a huge MI with a gross LV dysfunction, you are immediately taking him up for a primary PCI, whatever comes in, provided you can provide protection to your staff. If you cannot provide protection to your staff, obviously that doesn't come in at all, number 2. And number 3 is the risk for your staff and the waiting patients, right? So if you can take care of that, like Dr. Bino said that in Jubilee Hospital, they have the luxury of having 2 cath labs, the problem is solved. You keep one cath lab for people who are undiagnosed or COVID positive, and the other for routine cases. You are comfortable, right? But since most of us doesn't have that, the high risk we immediately take up. And the rest of them, you decide. If you think that because of staff risk, because of other factors, there is going to be delay, the ideal thing would be pharmacoinvasive therapy, right? So the resurgence of pharmacoinvasive therapy in India, especially for example in Kerala, is not because the person's distance from the cath lab. Okay, it is just because the change of scenario where we are bothered about the safety of the medical staff and of course the other patients who use a similar facility like a cath lab. Now, once we have decided to go for pharmacoinvasive therapy, I think there is universal opinion of all the panelists and the speakers that tenecteplase scores better, not just because the data available. And I would add that you saw that huge amount of data, like 20,000 patient data we have from our own registries where, now understand there are registries, right? In that Elaxim registry, we never compared it with some other agent or something, but we had a very good result. And all of us have got of our own experience that when we see a patient coming from a different center with an post tenecteplase thrombolized patient, very rarely you find a totally occluded artery and myocardium is damaged. You still have the time. So if you cannot do a primary PCI because of the COVID constraint, your next best option would be a pharmacoinvasive therapy. And in that pharmacoinvasive, I think it is no doubt that the choice of therapy would be a tenecteplase to go forward. Now, I think we are passing through very difficult times, especially in relation to acute coronary syndromes and especially ST elevation MI. In that confusion era, I think we had a fantastic discussion. I learned a lot, and I hope that it was useful for the patient who are listening. Thank you, Dr. Ranju. Thank you, Dr. Nejal, Dr. Sajan, and Dr. Bino. It was a fantastic experience. Your slides were all beautiful. And I would ask Dr. Omkar Swami, who is always with us. And I thank Dr. Omkar not because of anything, because your programs are mostly unbiased. And you open up and let us decide what we want to do. So you won't mind whether whatever product you deal with, whether it is good, bad, or suitable for one subset or the other subset. That is why I respect you. And whenever you call for a meeting, I am there because, it looks so free for us that, we are unfettered and we discuss whatever it is. We can freely discuss a difference between tenecteplase and an alteplase or a retiplase freely right in front of you. So, Dr. Omkar, last word before we go home.
Thank you very much, sir, for this such a nice deliberations and taking out the important pearls of wisdom. So we have 1 hour, 30 minutes discussion, and we understand what would be the best suitable for the patient. So ultimately, we are working for the patients, and we should see the best suitability of patient, irrespective of the pharmaceutical company and what the product we are offering. With this note, sir, we will stop here and we'll catch up maybe on another program with some time later with some new topics. With this note,
sure. But do keep the same faculty and the same panel. They're exceptionally good, I tell you.
Yeah, definitely, sir. Definitely. We'll have one more discussion, maybe another topic. We may take pulmonary embolism and something like that and have the same discussion and usage of maybe thrombolytics in pulmonary embolism. With this note, sir, let's stop here, sir. I wish a great time ahead. Stay safe, stay healthy. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Good night.
Thank you, all of us.